Hello everyone, my name's Sophie and I'm here with my colleague Stuti, and we're both researchers at the Nuffield Trust. And the Nuffield Trust is an independent think tank. We do evidence-based research aimed at improving health and social care across the UK. And we've done quite a bit of work on end-of-life care, and as part of that work, most recently we've been using OpenSAFELY. And today we're going to present on one of those work streams which looks at quality of end-of-life care. So just as a bit of background and context, this work started with the Deaths at Home project, which is now a published report. It was published last year by our colleagues at the Nuffield Trust. And this looked at deaths at home for people during the pandemic. So it took 2 time points before the pandemic and during the pandemic and compared service use. And we extended this project, and this graph here shows the first work stream of this project extension. So it looks at the trend in service use for people who died at home, and just to kind of pick out a key indicator here, if you look at GP team contacts, that red line there is the COVID pandemic. You can see that there was quite a significant increase, and this trend has been sustained over time. And if you wanted more information on this work, it's now published in a series of blogs on the website. And yeah, so it's really important that we track service use in end-of-life care. However, we did want to go beyond this and look more at quality of care and how to build measures in the quality of care that's received for patients at the end of life. So just as a really brief overview of the approach we took, so we looked at previous work that's used quality measures, but most of these focused again on service use and specifically emergency admissions at the end of life. So we took to reviewing the literature and looked to identify good elements of end-of-life care, and through this we identified 5 key elements, so specialist palliative care, advanced care plans, continuity of care, coordination of services, and anticipatory medicine. But we wanted to see how feasible it was to build these measures, so we started to look at potential codes that could be associated with these measures and looked at their usage to see whether this was feasible to do. And using all this information that we collected, we presented to our advisory group, which is built up of GPs, academics, policymakers, and patient and public involvement. And through this, we were able to discuss the feasibility of these measures, whether what we were seeing in the code usage was reflected in practice, but also the importance of these measures, both from a clinical perspective, but also from the perspective of patients, which is a really important element of this work. And based on this feedback, we chose to focus in on specialist palliative care team contacts and the advanced care plan. And once we kind of focused in on that, we were able to build more comprehensive code lists, and that then helped us to produce these measures. So the first one we're going to talk about is specialist palliative care. So this chart here shows the proportion of patients who died with specialist palliative care team contacts recorded in their GP records in the last 30 days or 3 months of life. And again, the red line indicates where the COVID pandemic was. And I think the first really key thing to draw out here is we're looking at really quite low proportions. So for all deaths, there should be a glowy line, which shows that this actually rose from 4% of patients to 5% of patients. So yeah, quite low proportions. And the green line at the top there, that shows people who died in hospices, and below that, people who died at home. So we would expect this to be higher than other places of death, mainly because a lot of specialist palliative care is provided by hospices or hospice at home services. However, as I said before, it's still slightly lower proportions than we would expect. So we took this to our advisory group and we discussed maybe the reasons for why we see such low proportions here, and they confirmed that it doesn't necessarily reflect what we would expect in practice, and a couple of reasons for that. One maybe being that patients may receive specialist palliative care in the hospital setting, for example, but also more related to the way that GPs code for specialist palliative care, as in they may be more likely to code for generalist rather than focusing in on specialist palliative care. So overall, we concluded that this first new measure was potentially not overly useful as a reflection of what's happening in practice.
Right. Okay, so moving on to our second measure on advanced care planning. That chart represents the proportion of patients with advanced care planning in their records organized by place of death. So that glowing blue line represents everybody collapsed across all categories. And in that 4.5-year period, it's gone up from 19% in March 2019 to about 27% in August 23. You'd notice that orange line towering over everything else, that represents those who died in care homes. So that vertical red line is the onset of COVID. Post that, numbers have dropped off a little. But in the 21 to 23-year period, that group has seen quite a stark increase. And then it's dropped off again after April 2023. Remember that line. I'm going to come back to it later. The third thing I wanted to point out on this chart was the purple line towards the bottom. That represents those who have died in a hospital, and that number has sort of wavered around 10% throughout the period of our study. Also another chart on advanced care planning, but this time organized by cause of death. So you'd see the green and brown lines towards the bottom. Those represent people who have died of a respiratory or circulatory disease. They have been least likely to have advanced care planning in their GP records. Those who have died of cancer were more likely, and those who died of dementia and Alzheimer's were the most likely. So coming to conclusions and takeaways. We've already reached that part of the presentation pretty quickly. So the main thing that made us scratch our heads the most with this project was wondering whether these results were reflective of GP coding practices or whether it was telling us what was actually happening. So you would remember that for that advanced care planning slide, those who died in a care home were more likely to have advanced care planning in their records than those who died in a hospital where perhaps they were interacting less with their GPs. Sophie had also mentioned that we expected higher numbers on that specialist palliative care measure. And then we were told that what may have been delivered as specialist palliative care was just coded as palliative care, so that may have been missed out entirely. So that was a big conundrum for us. Secondly, that line that I had pointed out earlier, that big orange one, quick recap, that represented those who died in a care home and advanced care planning records for those who died in a care home. In the 21 to 23-year period, there was that big increase. That coincided with the Enhanced Health and Care Homes program, which encouraged greater integration between primary care networks and care homes. So we sort of stumbled upon evidence of that in doing this work. Thirdly, I know that PPIE engagement is a non-negotiable part of good quality research now, but I just wanted to reiterate how helpful it was to be able to listen to people with lived experience of this. It really gave so much more color and meaning to all the work that we were doing. Fourthly, so many more future directions for this work. So Sophie mentioned other principles of end-of-life care that we couldn't look into, things like coordinated care, care coordinated between different services and systems, and continuity of care, care provided by the same provider. Those are really worth looking into. We unfortunately couldn't do that in the scope of this project. And secondly, we took a national overview of things, but looking at local data networks might lead you to perhaps richer, denser, more granular data that you could do more with, so also very worth exploring. I think that brings us to the end of it. You can scan that code and it'll take you to a page on our website that will describe all this methodology in more detail. And just a big thank you to OpenSAFELY and to all of you for your attention.